Welcome to Quick Care Bites. Today we'll be discussing non-invasive modes of ventilation, including NIV and high-flow nasal cannula. Broadly speaking, non-invasive modes of ventilation include that of CPAP, continuous positive airway pressure, BiPAP, bilevel positive airway pressure, otherwise known as NIV, or high-flow nasal cannula. Indications for non-invasive modes of ventilation would be that of either hypoxemic respiratory failure or hypercapnic respiratory failure, and it's important to distinguish between the two as it will affect which modality you choose. So why choose non-invasive ventilation? Some of the benefits of non-invasive modes are that spontaneous ventilation is maintained, it preserves the physiological pathways of airway protection, and it reduces complications related to endotracheal intubation and invasive mechanical ventilation. This includes things like ventilator-induced lung injury, ventilator-associated pneumonia, and the use of heavy doses of sedation or neuromuscular blockade to ensure patient ventilator synchrony. In addition, by maintaining spontaneous ventilation, diaphragmatic atrophy is prevented, and normal heart-lung interactions can be maintained. On the flip side, there are potential harms to using non-invasive modes of ventilation. In patients with significant lung pathology, hypoxemia, a dysregulated inspiratory effort, altered respiratory mechanics, and inhomogeneous lung inflammation can lead to a vicious cycle. Intense inspiratory effort from the patient results in high tidal volumes and tachypnea, and their injured lungs are exposed to a higher risk of volutrauma and barotrauma. This occurs as a result of patient's self-inflicted lung injury, whereby an intense inspiratory effort causes very negative pleural pressures, leading to a large swing in transpulmonary pressure and Pendeluft phenomenon. This may actually account for the increase in mortality when NIV or high-flow nasal cannula fails, and the use of non-invasive modes of ventilation may actually result in a delay in endotracheal intubation. So what then is NIV? NIV is a patient-triggered, pressure-targeted mode of ventilation. A positive inspiratory pressure is delivered above a set PEEP, and this inspiratory pressure provides a pressure gradient from the mouth to the alveoli, thereby increasing tidal volumes. It works by reducing work of breathing and improving VQ matching. It has beneficial effects on the left heart due to positive pressure ventilation. Hypoventilation and hypercapnic respiratory failure is best treated with NIV. In cases of pure acute hypoxemic respiratory failure, the effect of positive inspiratory pressure needs to be monitored to ensure that it does not lead to excessive tidal volumes, as that predicts subsequent failure. So what are the differences between a BiPAP and CPAP? So BiPAP involves giving a positive inspiratory pressure on top of the PEEP, and you have basically two parameters to set. You have the IPAP, which is the inspiratory positive airway pressure. This is akin to the peak inspiratory pressure on the ventilator. And you have an expiratory positive airway pressure, which is akin to PEEP on the ventilator. And the EPAP is what affects oxygenation. The driving pressure is the difference between the IPAP and the PEEP, and this is what actually influences tidal volume and thus minute ventilation. In contrast, CPAP delivers a continuous positive airway pressure at a fixed level. It is akin to PEEP on the ventilator. So if you set a CPAP of 10 centimeters of water, this means that a pressure of 10 centimeters of water is being given throughout both inspiration and expiration. Minute ventilation still occurs as the patient has their own respiratory effort and can inspire and expire on top of this positive airway pressure. FiO2 is then titrated according to need. So this diagram on the right illustrates normal breathing. So this is normal tidal breathing during inspiration and expiration. We can see that when CPAP is added, the pressure is higher, but essentially the curves look the same. In contrast, for BiPAP, there is an added inspiratory pressure support called the IPAP, and therefore the curve has a higher pressure rise to the peak of inspiration, and as the patient expires, pressure goes to the expiratory positive airway pressure. There are several interfaces available for CPAP and BiPAP. The first is that of the oral nasal face mask, which is illustrated in this picture over here. And problems with it are that there can be significant leak and it's uncomfortable for the patient and may result in pressure sores. The other interface that is used is that of the helmet NIV. It is advantageous in a sense that there's no pressure on the skin, and therefore better tolerated by patients and allowing for more prolonged use of the NIV. However, some problems are that patients who are claustrophobic may not tolerate it. You may actually require a higher level of PEEP to avoid collapse of the hood, and high gas flows are necessary to avoid CO2 rebreathing.
In a meta-analysis published in JAMA 2020, helmet NIV was shown to be superior to face mask NIV and high-flow nasal cannula in reducing the risk of endotracheal intubation and mortality. And there is some evidence supporting the use of helmet NIV in patients with COVID-19.
NIV can be used in a myriad of settings. It can be used to prevent intubation in patients with respiratory failure. It can be used as pre-oxygenation prior to intubation, and can be used as in the process of weaning and liberation from mechanical ventilation. So we'll look at the strong indications for NIV first. The two strongest indications for NIV would be patients with COPD exacerbation and acute pulmonary edema. In COPD, the use of NIV has been shown to avoid intubation in 80 to 90%, with a number needed to treat of 3 to avoid 1 intubation, and a number needed to treat of 10 to save 1 life. For acute pulmonary edema, the number needed to treat is 10 to avoid 1 intubation. In terms of mortality, CPAP has been shown to reduce mortality in several meta-analyses, and this has not been replicated for BiPAP. However, a subsequent comparative study called C3CPO between CPAP and BiPAP did not show a significant difference. So, in my opinion, if it's a patient with pure type 1 respiratory failure and cardiogenic pulmonary edema, I would probably opt for CPAP first, but if there is type 2 respiratory failure, or if the patient seems as if he's tiring out, I would then opt for BiPAP. Other strong indications for NIV would be patients with obesity hypoventilation syndrome and bronchiectasis with type 2 respiratory failure, and NIV can be initiated in a similar fashion as to patients with COPD. For mild to moderate acute hypoxemic respiratory failure, which is defined by a PF ratio of more than 150, NIV has been shown to reduce intubation compared to conventional O2, and this applies in immunocompromised patients as well. However, the use of NIV has increased mortality if NIV eventually fails, and therefore patient selection is extremely important. Moderately strong indications for NIV would be in patients with neuromuscular weakness or patients with chest wall deformity. And an NIV trial can be considered in patients who are hypercapnic or when their vital capacity is less than 1 liter and they are tachypnic, even if the carbon dioxide levels are still normal. For neuromuscular patients, we need to be cautious, especially if there's bulbar weakness, if there's drooling, pooling of secretions, they can't protect their airway, then these patients might actually be better off being intubated. In post-op respiratory failure, the use of NIV has been shown to reduce intubation in patients post-abdominal surgery and post-CABG. For extubation failure as a rescue, avoid in all cases except in COPD, as NIV has not been shown to prevent intubation and has demonstrated actually increased mortality by delaying intubation. Other moderate indications for NIV would be things like bronchoscopy or palliation. For palliation, usually NIV is only used in the setting if the patient was already initiated on NIV and failed. If the patient is simply in respiratory distress, it would probably be better to control symptoms with opioids, as NIV can be uncomfortable, it's claustrophobic, it causes pressure on the face. Lastly, looking at the column on the right, conditions in which there is insufficient evidence or evidence against the use of NIV. For asthma exacerbations, there's only one randomized controlled trial. NIV was shown to improve lung function, and most patients were discharged. But this begs the question whether these patients actually had a severe asthma exacerbation or not. In ARDS, NIV has a high failure rate of 70%. Pneumonia, NIV also has a high failure rate of 50% and has been shown not to reduce intubation. And other situations in which NIV should not be used as first line would be things like upper airway obstruction and any cases of extubation failure as previously mentioned. So really knowing the strength of evidence for the particular indication for NIV and the risk of failure would really affect things like how closely we monitor the patient and where these patients are sited. So consider closer monitoring in ICU or high dependency, especially when you initiate NIV in patients with only a moderate level of support from the evidence or in patients with mild to moderate hypoxemic respiratory failure. In such patient groups, there is a low threshold to declare NIV failure and proceed to intubation, as we will want to avoid a delay which could actually lead to an increase in mortality. The next indication we will discuss is the use of NIV as pre-oxygenation prior to intubation. I would strongly consider the use of NIV in obese patients and in patients with acute hypoxemic respiratory failure. A recent paper came out in New England Journal of Medicine in June this year, where it found that patients who actually received NIV as pre-oxygenation had a lower incidence of hypoxemia as compared to patients who received conventional oxygen. In liberation from mechanical ventilation, NIV can be used to hasten extubation in patients with COPD, so these patients may have failed SBT but are otherwise ready to be weaned. Another situation in which NIV might be used in weaning would be post-extubation to prevent reintubation, and we would strongly consider the use of post-extubation NIV in high-risk patients. Generally, the definition of high risk varies between studies, but the common characteristics are patients with COPD, heart failure, they are elderly, the age is more than 65 years old, they have previous extubation failure, hypercapnia before or after the spontaneous breathing trial, and patients who are obese or have a known history of obesity hypoventilation syndrome. Contraindications to NIV would include patients who are already in cardiac or respiratory arrest, patients with severe hemodynamic instability, severe metabolic acidosis, severe respiratory acidosis with a pH of less than 7.2. However, in COPD patients, you might still consider the use of NIV as these patients usually respond well and quite quickly. Other situations in which NIV should be avoided are in patients with multi-organ failure, active hemoptysis or hematemesis, facial surgery or trauma, patients with a depressed GCS who are unable to protect their own airway. So how then do we set up the NIV machine? In the ICU, the usual mode we use is that of the spontaneous timed mode. For IPAP, we'll start at 10 centimeters of water and titrate upwards in increments of 2, usually to a maximum of 24. COPD patients typically require a value of between 16 to 18. Neuromuscular weakness patients between 10 to 12. Acute hypoxemic respiratory failure generally less than 16. And the IPAP rise time we use is usually 0.1 seconds. For EPAP, we start at 5 centimeters of water and titrate again upwards in increments of 2 to a maximum of between 10 to 12. We'll monitor the driving pressure, which is the difference between IPAP and EPAP, looking at changes in tidal volumes as the driving pressure is adjusted. The FiO2 is then titrated to target SpO2. This is usually 88 to 92% in patients with chronic type 2 respiratory failure. The respiratory rate is set at 12 breaths per minute, but this is usually a backup as patients are spontaneously breathing and are usually breathing above the set rate. 30 minutes to 1 hour post-initiation of NIV, ABG is repeated, looking for improvement in pH, PCO2, and PO2. What should the disposition be for patients initiated on NIV? Different institutions have different guidelines. In my practice, I would place the patient in intensive care unit if there's a high risk of failure and subsequent need for intubation. These would very often involve patients who are on NIV for non-COPD reasons or in patients who have severe acidosis. To the high dependency unit would be patients in which NIV is likely to be successful, so generally COPD patients who are comfortable on the NIV. For most patients initiated on acute NIV, I would not send to the general ward because of the risk of failure. So generally, patients who otherwise have some goals of care discussion before and have been established to be not for intubation, then these patients I would actually consider sending to the general ward. In terms of predicting NIV failure, so to monitor the response to NIV, we usually repeat an arterial blood gas 30 minutes to 1 hour after initiation. And if this blood gas shows no improvement or in fact a worsening in pH or PF ratio, this would predict NIV failure. Specifically to the PF ratio, the number itself is important. So a PF ratio of less than 200 after 1 hour has been shown to have an increased risk of intubation, and PF ratio of less than 150 after 1 hour has been shown to be associated with an increased risk of death. Other clinical indices would be if the patient is persistently tachypnic or if they have high tidal volumes. Again, high tidal volumes of more than 9 to 9.5 mL per kg of predicted body weight 1 hour after NIV initiation has been associated with increased risk of intubation and death, and the likely mechanism in which this occurs is likely due to patient's self-inflicted injury. For specific indices, there is something known as the Harcourt score. The components include that of pH, heart rate, respiratory rate, PF ratio, and GCS, and a score of more than 5 would predict NIV failure. And the last context in which I would consider predicting NIV failure would be to actually reconsider the original indication for NIV. So NIV failure rates in COPD is between 15 to 20%, so fairly low. However, NIV failure rates for acute hypoxemic respiratory failure can range from 40 to 60%. So therefore, if a patient was initiated for this indication, I would have a much lower threshold to abandon NIV and proceed for intubation early. We'll now move on to the next mode of non-invasive ventilation, which is HFNC. HFNC works by generating a flow-dependent FiO2. It delivers a flow higher or equal to the patient's own inspiratory requirement and thereby diminishes air entrainment. Gas goes through the air-oxygen blender and generates a total flow of up to 60 to 70 liters per minute. It is heated and humidified and therefore is tolerated by the patient. In HFNC, you're both able to titrate the FiO2 as well as the flow. To understand how HFNC works, we have to understand the principle of air entrainment. Classically in medical school, we are taught that FiO2 can be estimated from this equation, where FiO2 equals to 0.21 plus 0.04 times liter per minute of oxygen. So as an example, FiO2 on 4 liters nasal prong would equal to a fraction of inspired oxygen of 0.37. However, this is not true because the concentration of oxygen that patients inspire depend very much on their own minute ventilation and the flow rate of oxygen. Take this graphic on the right as an example. The patient's total intrinsic flow demand is that of 26 liters. We are delivering oxygen through a nasal cannula at 6 liters per minute, which by the equation would calculate to come to 45%. The remaining 20 liters of flow that the patient wants, out of the 26, is actually from room air, and this is 21%. By proportion, the actual FiO2 the patient is breathing is probably closer to 21%. Therefore, HFNC works by reducing entrainment of air by utilizing high flow. By delivering oxygen at a high flow rate, it ensures that the oxygen flow rate always exceeds the patient's intrinsic flow rate. The heated and humidified air allows patient to tolerate this high flow, and a very precise FiO2 can then be delivered. Other physiological effects of high-flow nasal cannula would be that the high flow actually washes out carbon dioxide in the anatomic dead space, and the high flows also allow for delivery of PEEP, but this is generally a low level of between 5 to 8 centimeters of water. The consequences of high-flow nasal cannula would therefore be higher FiO2 levels and a more stable oxygen delivery compared to conventional oxygen, a reduction in dead space, and therefore a reduction in work of breathing, and by delivering PEEP, better VQ matching, as the PEEP would allow for alveolar recruitment. Indications for HFNC would include acute hypoxemic respiratory failure, typically in patients who have a PF ratio of less than 200. We would consider its use especially in immunocompromised patients, as invasive mechanical ventilation puts these patients at risk of ventilator-associated pneumonia. The added benefit of HFNC is that if the patient were to fail and require intubation, HFNC can remain in situ during the process of pre-oxygenation and intubation itself, with the FiO2 dialed up to 100%. HFNC can also be used to prevent reintubation in certain circumstances. We would use it in select patients who passed their spontaneous breathing trial, but the PF ratio is on the lower side. In patients who are high risk, defined similarly to be patients who are elderly, have heart failure, or COPD, or in patients post-cardiac surgery to prevent reintubation. So this is a table taken from Intensive Care Medicine Journal, summarizing the main clinical studies on HFNC in adults with hypoxemic acute respiratory failure. Generally, the studies have shown that HFNC improves oxygenation, decreases respiratory rate, and the study that I've highlighted in red is the famous Florali study, which looked at the use of HFNC in patients with hypoxemic respiratory failure and a PF ratio of less than 300, and they actually found that HFNC reduced intubation as well as a reduced 90-day mortality. In summary, the body of evidence for HFNC in acute hypoxemic respiratory failure shows that HFNC reduces endotracheal intubation compared to conventional oxygen. Compared to NIV, in moderate to severe acute hypoxemic respiratory failure where the PF ratio is less than 200, HFNC reduces intubation. In both the Florali and a subsequent meta-analysis in JAMA 2020, the use of HFNC has been shown to reduce mortality compared to conventional O2. The use of HFNC is also supported in immunocompromised patients, and this is based on the post-hoc analysis of the Florali trial. Included patients were those who had hematological or solid organ cancer, those with drug-induced immunosuppression or those on steroids, and patients with HIV, and they found that intubation rates were higher in patients on NIV as compared to high-flow nasal cannula. HFNC can also be employed to reduce reintubation rates post-extubation in patients with respiratory failure. It has been shown to be superior compared to conventional oxygen and non-inferior to NIV, and this applies to both high and low-risk patients. Studies have also found that alternating between NIV and HFNC may actually be better than HFNC alone in preventing reintubation. Contraindications to HFNC are fairly similar to that of NIV. So patients in cardiac or respiratory arrest, those with severe hemodynamic instability, severe metabolic acidosis, multi-organ failure, hypercapnic respiratory failure, active hemoptysis, hematemesis or epistaxis, patients with severe encephalopathy, or those with base of skull fractures or recent surgery to the nose. So how do we predict HFNC failure? Generally, if the SpO2 is less than 90% or the respiratory rate is more than 30, on HFNC settings of more than 70, this would suggest that high flow is failing. Clinically, if the patient develops copious tracheal secretions, they continue to be tachypnic and in respiratory distress, these are also signs of HFNC failure. In terms of a specific index, there is the ROX index, which is the SF ratio divided by the respiratory rate. A ROX score of more than 4.88 at 2, 6, and 12 hours respectively has been shown to be a low risk of progression to mechanical ventilation. In contrast, a ROX score of less than 3.85 would mean that the risk of HFNC failure is high and we should consider intubating the patient. Other signs of clinical deterioration would include acidosis with a pH of less than 7.35, worsening hemodynamic instability, or neurological deterioration. In the previous slides, we discussed that both NIV and HFNC can be used for acute hypoxemic respiratory failure. So how then should we choose one over the other? My take is that first we look at the degree of respiratory failure. So if the patient has mild to moderate hypoxemic respiratory failure, which is defined as a PF ratio of more than 150, we can choose either HFNC, NIV, or CPAP, as all three have been shown to reduce intubation compared to conventional oxygen therapy. This is, of course, in the absence of shock or other contraindications. Specific to COVID-19 related respiratory failure, helmet NIV may be superior to HFNC as demonstrated by the Hennevoort trial. In patients with moderate to severe hypoxemic respiratory failure, you would either intubate the patient or choose HFNC over NIV. My preference will still be for intubation as this is the safer option. This is based on the Florali trial, where HFNC reduced intubation and mortality over NIV in patients with PF ratio less than 200. And furthermore, we do know that the risk of NIV failure is higher when the PF ratio is less than 150, and NIV failure itself is an independent risk factor for mortality. The last factor which will affect my decision would be the patient profile. So we don't necessarily have to adopt a strategy that is different between immunocompromised and immunocompetent patients. However, based on the post-hoc analysis of the Florali trial, I might opt for HFNC in immunocompromised patients because of the mortality benefit. In contrast, if the patient had COPD, obesity, hypoventilation syndrome, or heart failure, I might choose to opt for NIV or CPAP. In summary, today we discussed the indications, contraindications to non-invasive modes of ventilation, how to go about setting up these modes of ventilation for our patients, and in which specific scenarios we might choose one over the other.